Good morning, everyone. I would like to just first of all invite everyone to come a little bit closer, if at all possible. You're very spread out, and we're optimistic this room will fill up, so we would like to make it less awkward and have you guys all come closer to the front. Good morning. You are in the Differentiated Service Delivery and Care Key Considerations for Successful Scale-Up session. My name is Anna Grimsrud, and I'm from the International AIDS Society. And I'm joined today by my co-chair, Dr. Bakton Kalingo from the International Treatment Preparedness Coalition. And we have an hour-and-a-half session with you today, and we're very excited to have you. I'm just going to give you a brief overview of the session. We're going to have the panelists up here each give a 10-minute presentation, and thereafter we're going to switch to a conversation. We're going to sit on some of these couches up here with some of our other panel discussants, and we're going to look forward to your questions. So you can start thinking about your questions now, because we are going to hopefully get you all to not just come up to the microphone and ask questions, but actually use your mobile phones or your tablets or your laptops to enter in questions that will then show on this big screen behind me. So I'll update you on that in about an hour, but for now you can start thinking about what your questions might be. So without further ado, I would like to ask Meg Doherty from the World Health Organization to come to the podium. Meg is the coordinator of treatment and care in the Department of HIV/AIDS at the World Health Organization in Geneva in Switzerland, and has been in this role since September of 2012. She's a trained epidemiologist and infectious disease specialist and continues to see and care for HIV-infected patients. And for those of you who would like to know more or get some materials, please make sure when you leave on entrance 0, there's also some materials that we're going to be referencing today, and that's what you're going to hear about. So go ahead, Meg. We look forward to hearing from you.
Okay, well, thank you very much, Anna, for having us here, WHO. And in particular, I feel like I have to say I'm channeling Shafika Saji and Lynn Wilkerson, who really are the authors and that have put quite a bit of effort into this document that I'll be talking about, which is the key considerations for differentiated antiretroviral therapy for specific populations. And I'm going to be talking about here children, adolescents, pregnant, and breastfeeding women. And this document, which I'm talking about here, is also what we call a sister document and should be read together with the decision framework for the same populations. So what do we mean by differentiated care? I guess you've probably been at a number of sessions already this week, so hopefully this is not new news, but we see that differentiated care or differentiated service delivery is an approach to optimize the health outcomes and the use of the health system resources. And central to this idea is equity. All clients need support, but that support should be commensurate to their need. And it's primarily about making services more accessible, convenient for the clients, and promoting the role of the community in the service delivery, as well as smart allocation of resources. So we do hope that this is a slide borrowed from Anna, so you may have seen this before, but from the WHO, we simply say public health approach is not just one size fits all anymore, that we actually do need to look at the diversity of the needs of people living with HIV. And in 2016, we incorporated this idea of differentiated care into our consolidated ARV guidelines. And at that time, we presented packages of care for different types of people living with HIV, those who are well, those with advanced disease, those who are stable and having a suppressed viral load, and those who need more support or in the unstable category. And these were some of the package of care elements. But at that time, we had made a definition of what was a stable client or a stable person living with HIV on therapy. And we were perhaps maybe too stringent in our definitions, but our definition was, and is currently, and now we're in the process of expanding that definition, of receiving ART for at least 1 year and no adverse drug events, and while that require any kind of monitoring. No intercurrent illnesses or pregnancy, good understanding of lifelong adherence, evidence of treatment success, either through 2 viral loads that are suppressed or no evidence of a rising CD4, so it wasn't required that a viral load be present, but that the person did look like they were responding well to therapy. And we made a special note at that time that rapidly growing children may need to be monitored more frequently due to a greater risk of disease progression and or treatment dose changes that might have to happen because of their weight changes. And now, over time, we've seen that perhaps we can relax a bit some of those requirements, and certainly the requirements for changing doses in children is not as frequent as we think. And once they're over 2 years of age, they should not have to come in that often for changes. Now, in this document, we also talk about these transitions of categories. So we're expanding the definition of who can be in that stable category, but we also understand that people can change. They can move between stable and unstable, and that a differentiated model of ART delivery should be able to address when people move in and out of those categories. And there's elements of readiness which you have probably heard about already in terms of the building blocks of the who, the when, the where, and the what. So what was the reason why we wanted to take a look at children and adolescents? Almost immediately after we launched our ARV guidelines, we had lots of people coming to us and saying, what are we going to do about children and adolescents? So we know that the services can be fragmented across the age group. Children are often very dependent on a caregiver, so they're very vulnerable to loss to follow-up. There is lack of decentralization, making it harder for kids and caregivers to attend together. And in HIV, in children is an aggressive disease, therefore more critical to maintain a good continuum of care for the child. So in many ways, we were seeing that the children and the caregiver or the parent were not being seen together. And in the worst case scenario, nurses who were not being allowed to care for children, which has been happening for adults regularly. There is also a strong rationale to address the exclusions of pregnant women. So pregnant women can have high loss to follow-up reported in the ante and postpartum period. This data is preliminary data that was presented last night at a WHO Inspire, which was a series of implementation science efforts to roll out peer support for keeping pregnant women in care. And what we saw, over 5,000 women enrolled into the Inspire project, that there is significant variability in attendance in terms of the last recorded. So having an ability to link the pregnant woman's care and timing is very important to ensure that she stays in care. And again, this shows that the definitions of retention and care and what this means for a woman, whether she's in antenatal care or whether she's in her service, really vary, and that we may need to have some of that standardized, but also find opportunities for women who are pregnant and staying in therapy in a decentralized model, that they could continue in that and not have to be switch services. So in this new publication that I'm briefly introducing to you, we define what the concept of stability for children, adolescents, and pregnant and breastfeeding women are, as well as for key populations, and you'll hear that later from my colleague, Virginia McDonald. And we propose the elements of care for the who, what, when, and where of delivering services to these populations. So you've seen some of these slides, and this comes from the time when we had a consultation with WHO and a number of partners, all of whom are recognized on this document, where we talked about these building blocks and what could around both the clinical consultation, ART refills, and what became evident is that we needed to add a third portion of our third area of this under psychosocial support, especially for the adolescent population and for key populations, but it's simply applicable to all populations. So how have we extended our definition? For adults, we continue with our previous base definition, ART for a year, no drug interactions or reactions, no intercurrent illnesses, understanding the importance of lifelong adherence, and evidence of treatment success through viral load or our CD4 monitoring. Children is the same as above, plus they should be at least 2 years, because after 2 years, their need for changing doses reduces, taking the same regimen for more than 3 months, and caregivers are oriented and counseled on disclosure process, because we know with children, the earlier they're disclosed to and understand their disease, the better the adherence is. For the adolescents, it's the same criteria as for the adults. And for pregnant women, we categorize these groups into women who are already in a stable situation and perhaps in a differentiated model when they become pregnant, or for women who become pregnant and start ART at the same time. So for those who are stable in care, one viral load that is suppressed in the last 3 months, if can be done and if is feasible, is ideal. And for those who are starting ART in pregnancy, the same for the adults, plus an HIV-negative results for her infant with a nucleic acid test, or what we call the early infant diagnosis test. Because that's a marker that actually the mother and pair are staying in therapy and that we're not losing that critical time to ensure that the infant gets prophylaxis, the mother maintains her ART, and that transmission from mother to child is reduced. This is a busy slide, but it's just to show you this. In the back of this document, you'll see a number of pages of considerations, those key considerations of how to address these services for these populations. And I'm briefly going to walk through the highlights. And what's highlighted in darker text is really what's new. So the elements of care for clinical consultations for children, adolescents, and pregnant women, we've again looked to extend the time between clinical consultations so that it's not once a month, that it goes to 3 to 6 months, certainly, as soon as they're older children. That the services for all can be provided in primary care, MNNCH care, or outreach, that we have nurses, doctors, clinical officers, and midwives who can provide the clinical consultation. And there should be a very comprehensive package of care that would include, based on the guidelines for the country, TB screening, prevention, treatment, lab tests, when including viral load, 6 to 12 months, and for children, immunization, and certainly disclosure for children. For adolescents, it's about adding in the mental health and drug and alcohol screening, and certainly the sexual and reproductive health. And for pregnant women, again, mental health issues, as well as linking to the MNNCH services. For the ART refills, very similar. Now we want the drugs to be provided, or prescriptions to be the delay in frequency, or spreading out the frequency across all 3 to 6 months. And again, now we extend where services can be provided to home-based refills, community organizations for all of them. Who can help them during this time? We have nurses, doctors, lay providers, but now we add also the category of peers. And lastly, we still need to remember that we have to check the disclosure at every opportunity for children, check whether they need to be referred up or back referral or up referral, and also ensure that pregnant and breastfeeding women are attending their antenatal services and actually getting the vaccines and making sure those are fulfilled. Lastly, we also identify and outline areas of psychosocial support and where that can be done. These we know will have to be somewhat more differential based upon the issues of each client, but either for children all the way to pregnant women once a month if there's a real need, up to every 6 months depending on the needs. But also we've added that we should get into the 21st century and start thinking about virtual consultations, social media. We should also consider when we have to up-refer, and that would be similar for psychosocial needs as for clinical needs. So in summary, the key considerations really pull together information about what we can do and how we can better serve clinically stable children, adolescents, pregnant and breastfeeding women, and how they too can now benefit from what we call differentiated ARV therapy delivery models. The services should be tailored in a way that we can keep families together as much as possible and to simplify access and reduce the cost. So having mother and children or caregiver and children having their services together is ideal. Clients who come in with advanced disease, you may have heard about that earlier in this conference, but those who come in with advanced disease or become unstable really need to be identified and up-referred for more intensive follow-up. And the whole idea is by having differentiated models, we actually serve the needs of the clients, but also reserve more time for the advanced disease patients who may need more services. We can address inequities, and we can actually enable communities to be more involved, and you'll hear about that this morning. And we want to highlight that this brought to us how clear it was to bring in the third element of psychosocial support. So with that, I would like to thank you and thank all the people who provided input to this. The leaders of this were certainly Shafiq, Asaji, Nathan Ford, and I have to also shout out to Lynn Wilkerson and Virginia McDonald, Annette Verster, and all the IAS teams and partners who have really put a huge amount of effort into this work. Thank you.
Thank you very much, Meg. Up next to give us youth perspectives on differentiated service delivery for families is Prosper Ndlovu. Prosper is a youth ambassador for Youth Voice campaign and also a counselor and youth club facilitator from WITS Reproductive Health and HIV Institute in Johannesburg, South Africa. He was selected as a differentiated care youth champion by the International AIDS Society. He was motivated to get involved in the HIV response to bring a different mindset to decrease stigma towards HIV and AIDS and help young people have acceptance towards their status and not feel burdened by coming to the clinic. Welcome, Prosper.
Hello, hello. At least you can hear me. I thought the mics would be too long. My name is Prosper. I'm from WITS Reproductive Health and HIV Institute in Johannesburg, South Africa. I am a youth champion. So today I'm just going to touch on adolescent and young youth perspective. Firstly, I'm very, very much happy that the WHO has finally included adolescents into the guidelines. That I'm very, but very happy about that. And this is an overview of the building blocks. As Prosper, I'm not just representing myself here. I'm with other 5 youth champions. So we have conducted and discussed with other young people in terms of what do they want, what kind of services do they want, what needs do they want to have in terms of clinical consultation, art refill, and also psychosocial support. So we spoke to a number of adolescents, and we have engaged with different kind of ages, different kind of background, and different kind of countries such as Zimbabwe, Malawi, Kenya, and Tanzania, and also South Africa. Now I'm going to touch on what we need on clinical consultation. What do adolescents need on terms of clinical consultation? Most basically what we need is youth-friendly services. We can have all the services, but if the clinic does not cater on the youth-friendly services, it is not enough for adolescents. So we need youth-friendly services to be implemented. And again, what also we need on clinical consultation is that we need shorter queues. We don't want adolescents, and we don't want the queues to be so long and take so much time, so we need shorter queues. And what we also need is that our art refill should not take too much long, and should be also be our art refill. Our art refill shouldn't be overwhelmed, but to be shortened. Okay, sorry about that. So on art refill, we need to be aligned with clinical school holidays. The reason why we want to be outlined with clinical school holidays is that we can able to attend school and also to be focused on clinic than having school and clinic. That makes us to have a lot of time, and that increases a number of young adolescents defaulting because they need to focus on school and also they need to focus on treatment. In South Africa, we have one of the best youth-friendly services in reproductive health, which caters for young people. So it's extended the hours for young people so that young people can able to access the services at any time. Okay, thank you. Thank you so much. And what do we need in psychosocial support? In psychosocial support, what we need is peer engagement. We relate better to peer than any other thing. We can have a lot of kind of discussions. We can have a lot of psychosocial support that we have, but if we don't have peer support, we cannot engage. It's hardly to engage with older adolescents, or elder people, I mean to say, it's hardly to engage with elder people than to engage with young adolescents. So it's easy to engage with young adolescents. It makes the services easy for that. And also in psychosocial, what we need is that we need our medication not only to be separated from the artery field, but our medication to be also be outlined with the psychosocial support, so that when we're having the psychosocial support, we also get our medication, and it makes clinical consultation easy, and it shortens the time of traveling, because in South Africa we had, when I was conducting my findings, we had young people complaining that they have to spend too much in transportation. So if our psychosocial treatment is outlined with clinical dates, it will make it much more easy. Now, I want to talk about the best module, which I know it works for young people. In South Africa, we have what we call a youth care clubs. The reason why I want to touch on this is because it works for young people, and young people have given good feedback on terms of youth care club. Youth care club includes those ones who are newly initiated, virally suppressed, and those ones who are not virally suppressed. So they engage with discussion, and when they engage with discussion, they give each other support, not only support from the peer educator or from the healthcare provider, but among themselves. So they build each other, and they're able to influence each other. Those ones who are virally suppressed, they can able to influence those ones who are not virally suppressed to be virally suppressed. Peer navigators, we have what we call peer navigators known as health connectors. They connect young people into the health system to those ones, especially those ones who are newly initiated, to know the right procedure, because sometimes the clinic can become overwhelming for young people, and young people don't know where to go and how to do things. And so the peer navigators are the good linkage for them. So, I'm very happy that the clinician guidelines for the region has been launched, which covers a lot of aspects for the ages of 10 to 24, and it also covers the building blocks of stable adolescents, unstable adolescents, and also initiated adolescents, and also covers on terms of how to move from adolescent stage into adulthood, because sometimes young adolescents find it hard from moving from younghood to adolescent. Last but not least, I want to invite you all. They say where there's young people, there is life. So if you want to experience the life that we have, we invite you to our Changing Landscape. That will take place at 2:30 today. I'm hoping you to see you. So before I close, I want to close with this. The greatest impact that we can make is to change HIV into the new definition, which I have made. I've changed HIV into a new definition as human impact to victory. We need to make a good impact to young people so that they can become victorious in their suppression, and they can able to take their drugs in a proper way. I would love to leave this motivation that HIV lives with me, but I am in charge of it. Thank you.
Thank you, Prosper. I would next like to invite up to the podium Dr. Virginia McDonald. She is a consultant to the Key Population and Innovation Prevention Unit of the HIV Department of the World Health Organization in Geneva. And she's also the lead author on a commentary in this new supplement from the Journal of the International AIDS Society, where she talks about the call for differentiated approaches to delivering HIV for key populations. And so I'm sure you can find out more there. Thanks, Virginia.
Okay. I'd first like to say thank you to IAS for inviting me to speak here. I'm so happy to be talking about key populations in relation to differentiated service delivery. I think too often when we talk about key populations, we think about prevention, we think about testing, but of course, they need to be treated too, and they have specific issues accessing treatment, and there's ways that we can address this, and I really believe that differentiated service delivery allows us to address a lot of these issues. So you've probably seen slides like this various times at the conference. This is from UNAIDS' most recent report. And what we see is that globally, 44% of new infections occur among key populations and their partners. In the sub-Saharan African region, this is 25%. In all regions outside of sub-Saharan Africa, it's 80%. So I'd like to just point out that we at WHO define key populations as sex workers, transgender people, men who have sex with men, people who inject drugs, and people who live in prisons and other closed settings, who are not shown here on this chart. And the reason we include these populations is because they are all criminalised. They all are at high risk of HIV. They all have social and legal issues which make barriers to them accessing services. And just a little bit more about those barriers. I've adapted this from various modelling studies which show that there's a direct link between criminalisation of behaviours and increased HIV risk. And how this happens is that criminalisation of behaviours leads directly to stigma. I like to try and imagine a world where drug use was not criminalised and how we would feel about drug users in this situation. And I believe that, without criminalisation, they would not be nearly so stigmatised. Criminalisation also leads to increased human rights abuses and violence experienced by key populations, and an inability for them to report and redress these issues. This leads to reduced access to prevention, testing, treatment services, inconsistent condom and needle syringe use, leading, of course, to an increased risk of HIV infection and other poor health outcomes. And this then leads back to stigma. Someone who's a key population member and also HIV positive is facing double stigma. How does this affect them when they're trying to access treatment? This comes from a study of 200 ART prescribing physicians in Malaysia who were asked a very simple question. When someone presented to you, would you start treatment straight away or would you delay treatment? And they asked this about people, various populations attending, and also at various CD4 counts on presentation. And I just want to look at the bottom solid black line and the end of that, which shows that 45.3% of these physicians would defer treatment to a person who injects drugs who presented with a CD4 of 17. And of course, we've seen lots of cascades. We don't actually have a lot of cascade data for key populations. And I've taken liberties here because I'm presenting country data and then UNAIDS global data. But just to note that how far below the estimates of general population, those on treatment and those virally suppressed and even those diagnosed, key populations are. And this is partly the result of the stigma that's experienced at facility-based services by key populations. So here again, Meg talked about this. We had a great consultation in November, and various members of key population groups participated and other people. And again, really happy that key populations were included in this document. So just a little bit about the relevant WHO documents which guided the development of this key considerations paper. These recommendations come not only through the ART guidelines, but also through the key population consolidated guidelines which WHO has developed in 2014 and updated in 2016. And just to look at the first point, the trained and supervised lay providers can distribute ART to adults, adolescents, including those who are members of key populations and children living with HIV. I'd like to point out that these lay providers could be members of key populations, they could be peers, they could be peer navigators, there could be other people working at key population-focused community-based organisations, and I think that's important to remember. The other relevant recommendation that comes in both these guidelines is about decentralising ART delivery. And again, I want to just look at the third bullet point, which says initiating ART at peripheral health facilities, but with maintenance at the community level between regular clinical visits. And this can be at outreach sites, health posts, home-based service, and community-based organisations. And again, I want to point out that these could easily be key population-focused community-based organisations. And our final recommendation, which is specific to those people who are opioid dependent, is that where opioid substitution therapy is provided, ART can be initiated and maintained in people who are eligible for ART. And this last recommendation has a really strong evidence base. Again, Meg has already described to you the criteria for defining a clinically stable adult. And just to say that a clinically stable key population member is no different from any other adult who is deemed clinically stable. But there are some specific considerations that came up during the consultation in November that we need to remember for people who use drugs. We say everyone living with HIV who use drugs should be offered HIV treatment, and definitely active drug use should not exclude them from this. But we recognise that some people may require additional support. And this additional support could be through adherence counselling, through peer navigation, through advice to be timing, taking ART with other drug use. And also, as Meg mentioned, we're talking about equity. So with any other adult, people who use drugs need to be, the decision to reduce their clinical visits or ART refill should be made on a case-by-case basis. So I'm now just quickly going to talk about these building blocks, which again, you've probably heard plenty about. The first building block, when. This is no different from any other adult. We can use the same rationale we use to decrease ART refill visits, clinical consultations, the same rationale for key populations as we use for any other adult. But when we talk about the where, this is when it becomes a little bit different for key populations. Again, we notice that key populations feel uncomfortable often accessing facility-based services. So recognising that ART refills and clinical consultations could take place at KP-focused community-based organisations, at OST clinics, within prisons and other closed settings. I'd like to just point out that psychosocial support is something that many key population organisations, peers and peer navigators are experts at. So imagine that they could continue doing this important work that they do so well. Again, the who may be different for key populations, and as I mentioned, this could be lay providers, peers, peer navigators, outreach workers for the ART refills. And we've seen many presentations, I have because I've been attending all the KP sessions, that talk about the importance of peer navigators and what a difference they can make in linking key populations from testing services into treatment services. But I also would like to think that they could have a role in ART distribution, reducing that barrier between testing and treatment. For clinical consultations, yes, this is a nurse, a clinical officer, or a doctor, but these can be seconded to CBOs which are KP-friendly or through scheduled visits to these same organisations. And some community-based organisations which work with key populations already have doctors who are doing outreach, who are there working with these organisations. And they're doing testing, and they're doing STI screening, and they're treating STIs, but there does seem to be a block about what they can do with HIV treatment. Again, they're KP organisations, peer navigators, all these people are experts in psychosocial support. The what might be slightly different as well, although I think everyone should have access to prevention to prevent onward transmission of HIV. The what here is based on the comprehensive package of HIV services which we recommend in our consolidated KP guidelines. just to point out that harm reduction and other prevention commodities could be provided at all of these events when you have contact with key population members. Specifically for prisoners and people living in closed settings, they need support. If they're receiving treatment while they're in prisons, they need support to continue to access this treatment after they leave prisons. People who are receiving ART in the community and then entering into a prison system where maybe that ART is not always available, and unfortunately that is the case in many prisons and closed settings that don't have health programs. We need to try and make sure that they're continuing their treatment. And particularly about psychosocial support, that for key populations, part of this, which is, again, as I say, already provided so well by the key population organisations, is responding to violence which is experienced at high levels by key population members. So I like to say inclusion, not exclusion for key populations. And I just have been speaking about a very specific group of people who are stable and who have been on ART for 1 year. But I know that the differentiated service delivery approach is not just about them, it's about tailoring services to people's needs. So I think often with the key population members, the issue is not to move them out of facilities only. The issue is to bring them in and let them receive treatment. So I'd like to think that in the future we can be talking about key population organisations having a role in initiating and helping people with adherence in the initial period, and those people who are struggling to maintain ART, that the community-based organisations can have a greater role in this. So looking ahead, I went to a really fantastic session organised by Linkages about implementation science. And I think we need to implement this. We need to see what key population community-based organisations can do and evaluate it at the same time. We don't need lots of randomised controlled trials. We already know that differentiated service delivery works in the general population. There's no reason to think that this is not going to work within the key population organisations. And as I said before, we need more consideration of how we can help those non-stable clients, how we can help key populations initiate ART. I'm really happy that IES, I believe, is going to work to continue to develop more frameworks, much like they developed the framework which Meg was talking about for pregnant women, children and family members, one for key populations and also for HIV testing services, where we have a lot of recommendations about how to differentiate HIV testing services, be it through community-based or lay provider. It really mirrors what we're saying about ART delivery too. And yeah, so I think that's really important. Thank you for letting me speak, and yeah, thanks.
Thank you very much. Thank you very much, Virginia, for that. Following that policy perspective on key populations, I'd like to switch to getting to hear the key population perspectives, actually, from Othman Malouk, my colleague, who's the vice chair of the board of directors of the Global Forum on MSM and HIV. He works at the International Treatment Preparedness Coalition as an intellectual property and access to medicines lead. Othman's role at ITPC really is about coordinating a global consortium funded by UNITAID. He also is engaged in MSM HIV work globally through the forum and his country in Morocco. He was actually involved in launching the first MSM program in MENA. So welcome, my friend, Othman.
Good morning, ladies and gentlemen. Thank you for the IAS for inviting me to speak in this important session. Just maybe to start, what I'm going to say is maybe relevant for some categories of key population, including men having sex with men, sex workers, transgender people, and people who use drugs, but not really for prisoners, which is a kind of specific population, since people in prisons do not have really the choice of the services that they may have access to or not. So you are not going to learn anything new with this slide, but I think it is important to remember that HIV prevalence is disproportionately high among key population in general, including in countries where the epidemic is generalized. So if we see this slide on prevalence among MSM in comparison of with the adult general populations, we see that everywhere in the world, in all regions, from Middle East and North Africa, Sub-Saharan Africa, the Caribbean, etc., key population and MSF and MSM bear a disproportionate burden of the epidemic. When it comes to, we don't have a lot of cascades that are really specific to key populations, but according to this study that has been carried out by the Global Forum on MSM and HIV, so it's really about MSM, we need to be very cautious about these results because it's an online survey, so people who responded to it are really people who have access to internet and who are connected to MSM networks who have disseminated this study. But even having the fact that people are really connected and having access to information, so we have a high rate of people who have had a test and results. But then when we go to treatment and we see that only among the 2,500 people who have responded to the survey, we have only 107 who are really virologically suppressed. We need also, so beyond the epidemiological data, we need to remind ourselves why key populations are key. And actually, it's not only about prevalences, it is because these populations face high levels of stigma and discrimination. They face violence and human rights abuses. They face criminalization of drug use, sex work, some same-sex activity. So all of this needs to be taken into consideration when we are speaking about any model of service delivery. What is important to remind ourselves also is that very often this violence and this stigma and discrimination is really institutionalized, and it is really exerted by the countries, by the authorities like the police, etc., who are supposed to protect, in theory, citizens and people. So for us and for civil society and key population networks, any differentiated care model should require smart investment and not divestments. We need the thorough assessments, screening, diagnostics. We need safe spaces where people can get access to the services. I speak about safe spaces for the users, but also safe spaces for and protection for people who are providing these services. We need interventions and services that are principled, that are accessible, acceptable, evidence-informed, and right-based. We need participatory approaches that are that center the community and particular attention to the specific needs of each population. How people are treated matters, and according to the global survey of the MSM-GF, we see here the determinants that makes, for example, that people are going to take or not to take testing. So we see that connection to the gay community, to comfort with providers are really determinants that are in favor or that encourage people to seek services and to take them. And we see determinants like homophobia, violence, stigma are determinants that make people not use these services. Funding is very important also when it comes to key populations. So the Global Fund invests $4 billion per year to fight the 3 diseases, but among these, only 254 million are invested in key population. And for example, when it comes to MSM, only 82 million are invested in the services. So community organizations and key population organizations are already playing a key role. And if we see, for example, according to the Gay Men Health and Rights Survey, that accessing services through community organization, in this case LGBT-led CBOs, has dramatically large and positive in association with utilization of services, and we have here some determinants for services. So if from the perspective what could community-based organization do or consider in differentiated service delivery? We think that they can play an important role in delivering and tailoring services. They can provide safe spaces where people can come to seek and use the services. They can link, if they are not providing the services themselves, with friendly healthcare providers. They can drive demand for quality, for evidence-informed and right-based services, monitor service implementation and document human rights abuses, and mobilize for advocacy. However, if we jump into any new concept, this doesn't mean that we should abandon what is being done now, and especially when it comes to enabling environments. This is not accomplished yet, and we need still more investment on that. We think that the level of investment in key population remains low, and this should not drive the funding, the little funding that is available, into other directions. We think that key population beyond ART, they should have access to full packages of services that are tailored to their needs, and we need more protection and safety for when it comes to spaces, when it comes to the services, and especially to the community personnel who is involved in this. One important thing is community monitoring. I think it is going to work if we have really communities that are involved in the monitoring, things like community observatories, and we need systems and mechanisms to receive feedback and complaints from key population when there are any problems. Just to end, I think you have heard in the beginning in the opening ceremony this sentence, and many times it has been repeated, so nothing for key populations without key populations, so nothing with us, for us without us. Thank you.
And our last presentation in this session before we switch to conversation mode is from Dr. Tsitsiapolo from the Ministry of Health and Child Care in Zimbabwe. Dr. Polo is a medical doctor and a public health specialist. She's been practicing in Zimbabwe in the public health system for over 18 years. And we're really excited today to have her tell us about a really best practice example from Zimbabwe in terms of how their guidelines already address these specific populations. So thanks very much, Tsitsi.
Good morning, everyone. Thank you to IAS for giving me this opportunity to make this presentation. I would like to acknowledge the Ministry of Health and Child Care for Zimbabwe for its leadership and commitment towards the HIV response in the country. Zimbabwe has a population of 13 million people, and we estimate that about 1.3 million people are living with HIV. We have a prevalence of 13.8%. Which has fallen over the years. However, it is staggered at those levels because of improved survival of people living with HIV on treatment. We've seen a fall in terms of the HIV incidence, which is now 0.48%, and we have got a high burden of TB-HIV, which is at 70% TB and HIV co-infection rates. In terms of differentiated and service delivery models, we decided to embark on this process of differentiating services in order to improve the quality of HIV services because our program has matured over time. Currently, we have over 1 million people that are receiving treatment, but we wanted to focus on the quality of HIV services. We also wanted to look at client satisfaction to improve on that area, and to improve on efficiencies in terms of health systems, considering the resource-constrained environment that we're living in. So in 2015, we crafted our first operational and service delivery manual, which was a document to accompany the clinical antiretroviral guidelines. And these included some components of differentiated ART delivery, focusing more on stable adults. So in 2017, we updated the Operational and Service Delivery Manual, the OSDM, and we focused on the continuum of care from HIV testing to long-term retention. We also included other populations that we previously excluded, these included families and key populations. We also updated our job aids to help health workers provide as they see clients. So, so this is just to illustrate the very first version of the OSDM in 2015 and the new version, which was released in February 2017. So we do have these revised documents. So we used the health systems, these building blocks, the when, where, what, and who to consider the service package for adolescents as an example. In terms of when, since most of the adolescents are at school, so we looked at extending working hours for health facilities, and including weekends where services can be offered to adolescents. In terms of where, within outpatients department, and also providing services within schools and colleges and door-to-door services for testing. And also in terms of who provides the services is what has been spoken earlier on. Mobilization is done by adolescent peers and testing done by older adolescents. And in terms of the what, in terms of the services, we incorporate SRH education and also family planning advice and services. In terms of we also considered some specific subpopulations, and using the same framework, we looked at expanding the eligibility criteria for patients to fit into this criteria of being stable. So we have endorsed 5 models in terms of managing refills, refills for stable adult patients. And this is just to illustrate our definition of a stable client. Both patients on first line and second line fit in this criteria. And it also depends whether viral load is available or not available. We are still rolling out our viral load testing, and therefore there are instances where we have to use other criteria, the immunological criteria and the clinical presentation of the patient. Of note is that we look at a patient who has been on treatment for at least 6 months on their current regimen, and they're virally suppressed, and they don't have opportunistic infections. So in these instances, in terms of frequency of follow-up, where there is viral load, where it's offered routinely, then it's once a year. But in many instances, we are still reviewing our patients 6 monthly, because in many cases, we still have limited access to viral load. And we've actually embraced the policy of multi-month prescriptions, where we offer 3 monthly refills to patients who are stable on treatment. So here we have 5 different ART refill options, and these are embedded within our OSDM. We have the fast track for individual refill, where patients go directly to the pharmacy and get their medicines. We also have the club refills, which are facility-based, facilitated by a healthcare worker. And we have the outreach model, which has been there for many years, I must say, where a team goes out to hard-to-reach areas and offers a package of services. We also have the CAGs, community-based client-led group refills, and family member refill. We also encourage families to come together and receive services on the same day, under the same roof by the same health worker. So these are the 5 refills. So within our OSDM, we also have the building blocks for each of these different refills that we use, and step-by-step guidance in terms of the how to actually deliver that particular model. So we have like detailed SOPs for each of these models, and this is just an illustration of the CAG refill. So we have approached differentiated art delivery for families and key populations, and we also went through a process through stakeholder engagement to come up with, to determine the eligibility criteria, and using the building blocks to determine this kind of models. And we set out specific SOPs for each of these. For example, children who are stable on treatment. We looked at the age categorization, children from 0 to 2 years. These need to be seen on a monthly basis to align with their needs for growth monitoring, for immunization within MNCH. And then children from 2 to 5 years, these are seen every 3 months in terms of their ART requirements. And those children above 5 years, they're seen every 3 months until they receive adult doses of medicines and they're fully disclosed to. And then for mothers and fathers, they should be seen on the same day as their child in the MNCH. So we also we have embraced the family-centered approach to care, where families should receive care on the same day by the same health worker. So which models allow access for stable children who have been adjusted for children? The family member ART refill model and also the club refill model. So we also have adolescents that who are stable on treatment, and these are adolescents who are on adult doses, who have been fully disclosed to, they're virally suppressed, they do not have current opportunistic infections, so these can actually be seen 6 monthly for their clinical visits and 3 monthly ART refills, just like the adults that are stable on treatment. They can receive a couple of or refill options like the family member ART refill options, facility-based adolescent group refills. We encourage adolescents to be part of this group refills where they can also get some information and psychosocial support within those within that model. And also the fast track. There's some that may opt to just come and get their medicines and go back to their business. So we also have that as an option. So for stable pregnant and breastfeeding women, we've also incorporated this particular subpopulation. PMTCT and antenatal and delivery and postnatal services, they should be integrated. What we mean is that these services should be provided on the same day, under the same roof, by the same healthcare provider. And so there are some mothers, we're seeing an increasing number of women who are already on treatment when they present to ANC. So for these women who are already in certain medicine refill options, we encourage them to continue with those, while at the same time they attend to the ANC for all the ANC requirements. For those that contract HIV and they are put on treatment while they are pregnant, then they can be offered ART within the MNCH setting, or they can opt to also receive care at refills from the other options that are available for stable adults. I'll skip that slide in the interest of time. Moving on to stable key and vulnerable populations, we went through the same system in terms of determining the eligibility criteria, and we came up with this, that it's just the same as for the stable adults. And in terms of when, where, who, and what, we have a few exceptions. For prisoners, for example, we recommend that they get monthly refills because they are in a constricted environment. It's easy to manage their medicines on a monthly basis, but for their clinical reviews, we recommend 3 monthly while they're incarcerated. For mobile populations, we do have a lot of these, especially within the southern part of the country. So we offer 6 monthly refills for such individuals. And family members can actually come and collect medicines on their behalf. For all key populations, we also make considerations for stand-alone services, which are mainly offered through our partners, where it's feasible, and this is what is happening, especially for sex workers. And we can use peer expert clients to support in terms of refills. But we also see some key populations that want to access services from the public health sector, so we also provide those services. Which models allow inclusion of stable key pops? All the 5 adult models that I presented earlier on can also they are also extended and used for stable key populations. And we also consider to group, because key populations are different, so we also encourage them to receive these services within their own sub-population. So I would like to conclude by saying that we are actually rolling out our operational and service delivery manual together with the clinical guidelines and the job aid. And we've decided to use the mentorship program as our driving force towards orienting health workers and supporting sub-national level health workers in terms of these DSDs. So we've already conducted some national level sensitization for mentors of mentors. from across the provinces, and they're cascading the training down to sub-national level. So the mentors are training the mentors at sub-national levels. We've also conducted some training and sensitization of tutors from nursing schools for them to incorporate DSD elements within their pre-service training curriculum. So we're looking at opportunities to also expand to other pre-service curricula. We've also recently, 2 weeks ago, revised our integrated HIV training curriculum to also update with new global guidance and also include some aspects of DSDs. We're working closely with civil society organizations, and some of them are recipients of grants where they're actually also pushing the agenda of DSDs, particularly those at community levels, at CAGs and others, focusing on areas that are hard to reach. We've also reprogrammed our resources, including funding from a Global Fund and others, to really focus on implementing DSDs. I would like to thank you and also to acknowledge all the support from the different collaborators in preparing this presentation. I thank you.
Thank you very much, Tsitsi. So now we are going to switch from presentations to chatting. We're going to have a small little talk show. I think it's one of those things that I think would be useful to, and Anna is going to give us details. So in preparation for that, I'd like to invite two individuals, because this is a chat session where we need to look at, yes, we've talked about DSD and what it is and what people are doing, but it's also important to talk about resources. So I'd like to invite Ade and Peter to the podium. Ade, who is ahead of Peter, is a senior advisor on HIV/AIDS at the Global Fund. Dr. Fakoya has worked for over 10 years as a medical advisor to aid organizations in the United Kingdom, Asia, Africa, and Eastern Europe. Dr. Peter is a senior program officer at the Bill and Melinda Gates Foundation. And prior to joining the Gates Foundation, he spent quite a bit of time in Africa, especially in Liberia, working with the Clinton Health Access. So welcome, folks. Anna, I'll be joining shortly, but over to you.
Great. So what I'd like you guys all to do now is help us in this kind of talk show conversation. And so for those of you who aren't yet on your mobile phones or your tablets or your laptops, if you can get them out. Some of you are already on them, so now it's okay because we're going to integrate it into the session. And we can project the slides, and I'd like you to go to slido.com. And when you go to slido.com on your mobile device or your tablet or your laptop, it will ask you for an event code, and that event code is 7387, and that's going to remain up on the slides during this conversation. And the idea is that you can type in your own questions to ask our discussants who are up here, or you can also give some thumbs up to questions that other people have asked. And the idea here is really to talk about these key considerations and these specific populations and moving them forward. And so we would like to use this platform so that it's not as daunting in this big room to walk down to the microphones, but rather that you have a chance to type these things in. I see one of my questions has a thumbs up, so at least somebody has managed to log in and to do that. So I'm going to turn over to Bactrian and come join him. I'm also going to push this screen so you guys can see. Sure, so I think if we can get that Slido back up on the screen as well, great. So the first question now has 8 likes, so we'll go with that. So, Ade, how does the Global Fund support the implementation and scale-up of differentiated ART delivery? And is there specific funding for the specific populations that was mentioned? So how do we target services for children, adolescents, pregnant breastfeeding women, and the key populations?
So thanks, Anna, and thanks for IAS for inviting me here and being able to talk about this. Before I will answer that question, before I do that, I just want to say 2 or 3 quick things. Firstly, I think this is a really important session, and thanks to all the speakers, because I thought they gave some very excellent presentations and really got to the heart of the issues. The second thing that I would say is that differentiated models of care is very important for us. It's part of our work on program quality and efficiency, which is integrated into our strategy. So it's at the very heart of what we do. We see it as the next big thing. So those of you that are in the room, you're in the right place. And next time we have this session in 2 years, it will be full because people will recognize how important it is. The other thing that I would say is it's not just about efficiencies, it's about good clinical care and good practice. I really want to stress that point because I don't know if Kenley's in the audience, but I'm going to shout Kenley out because I was on the way here. Kenley, who most of you will know, was saying he had some reservations on it. So I do think there's a bit of work to do convincing people that this is very, very, very important. So to answer your question, we have been working on this with you guys, a number of different organizations, for about 2 years. I can't actually see the question, actually. How do we support it? So we've endorsed the guidance from WHO. We've actually developed our own guidance on differentiated model service delivery, which is on our web. In terms of instructions to countries, we're expecting countries to differentiate their care. So when you go to the Global Fund and you do an application, you have to fill in modules, and as well as modules for the key populations. So all the key population groups, you have to fill in the service delivery modules for those populations. There's also, when you come to request ART, and I'll give some figures in a moment, you have to, we're expecting countries, and a TRP which assesses the proposal, are expecting countries to put in what they're going to be doing about differentiated service delivery. So as I said, it's fully integrated into what we do. Now, some countries are already doing it, and I'll finish on that, just to say, I mean, you've heard from the great work from Zimbabwe, and they're really leading it, but there are also other countries, Kenya, Uganda, Ghana, which was discussed earlier in the week. And also, I know that in a week or so, India are going to be holding a big conference on differentiated service delivery models. So for a lot of countries, they're starting to do it. I think the other thing that I would say, 2 other quick things. One is that these models, these innovations are happening anyway. The real challenge is to identify them, test them, and scale them up. So that's the challenge for everybody. So I would recommend people have a look at Wafa's presentation at the plenary yesterday, because she gave a lot of good examples of the kind of questions that we need to ask. And an additional question I would say as a funder is we really want people to be thinking about how we track the resources, just so that we're able to get the good evidence about how this is working. And then I had a final point, which I just wanted to say. I have time? Okay. Oh, in the next time. So let me stop. I had one more point, but let me stop and hand over, and then we can go on.
Thank you, Ade. Peter, the Gates Foundation has previously put out calls for grant submission for innovative differentiated ART delivery models. Does it intend to do so again?
Thank you for the question, and I want to echo Ade's comments about thanking the organizers for inviting me to participate, and really thank the presenters for really a thoughtful ordering of the presentations and thoughtful presentations. It's very nice to finish up, to start with the normative guidance, to hear from the stakeholders, and then hear how countries, or at least one example country, is really taking this forward. On the question, which has just gotten lost, but it was about sorry.
It was about that the foundations previously put out calls for submission of innovative models, and is this something you intend to continue doing?
Okay, so thanks for the question. Actually, no, we don't intend to put out calls, and specifically, we're really focused on scale up at this point. I think there's a lot of questions that are out there, and the people that are the best situated to figure out what those questions are at the country level. It's the leadership from the Ministry of Health, the stakeholders in the country, including the donors, the other implementers, and the civil society organizations that are there. And actually what we've done is, the way our theory of action, if you will, goes, is we've worked with WHO and IAS and many stakeholders on developing the normative guidance that was presented here. The idea is then to take that normative guidance and which requires a higher level of evidence, and identify operational guidance, sort of a cookbook, if you will, of this is if you go to the chapter on stable patients or even stable adolescents, here's the bunch of recipes that have worked in various countries, and if you're thinking about what would work in your setting, here's what 3 other groups have done, and here's the documents, and here's the SOPs and the toolkit and all of the things really that Zimbabwe has already done. Nobody should reinvent the wheel, or Uganda has done a lot of amazing stuff, and many countries have lots of good examples. So we have organized a community of practice called Sequence. Some of you may have heard of it earlier. It's facilitated by ICAP. And it's a group of countries now, I believe 9, maybe 10 countries, that have come together with their ministries of health, their donors, their key civil society implementers, to learn from each other and think about what are the next steps. What are the areas that they have already been well evaluated, that they can just adopt and move forward and scale, and where there's gaps, to co-create, to do it together. So let me stop there before I go on too long.
So I'm going to go back and say you've got this community of best practice. There's obviously some evidence, but there are some hesitations regarding if there's enough evidence. And we have a question here about whether or not it makes sense to do randomized control trials in this context if we're focused on scale-up. So I would be interested to hear your musings on exactly what sort of research approaches we should be taking given the stage that we are in the epidemic and given the stage that we are in the implementation of what we already know works. Either of you.
I can go first. So there's certainly areas where randomized controlled trials are still needed, and that's areas where we're putting people at risk, and there's real questions about whether there's equipoise or not. But I think for many of these cases, people are going to vote with their feet, and I think we need to trust the clients and we need to trust the healthcare workers about, hey, this model works for me as the healthcare worker trying to provide it, or this model works for me as the client who's trying to access it. Because if we're going to go through a lot of trouble as a healthcare worker to set up a club, and then it turns out that nobody really wants to participate in that club, I'm pretty quickly going to figure out that either I've got to change the way I'm implementing that club, or I'm going to, maybe try something totally different, and people are going to come back to care. I think we have to trust what's happening and respond to patients and not feel the need to differentiate between small things and test them out in our most rigorous ways. That said, I think that there are areas where people have genuine concerns, where there's hesitancy. One area that I'm particularly excited about is the idea of thinking about, I think Othman said it, he says how people are treated matters. And I think that we are not doing a good enough job taking into account what patients, what clients think about the services that they're receiving. Nor are we doing a good enough job thinking about what healthcare workers are saying about the services that they're able to provide. You have that line of 100 people out the door. It's very difficult to provide services. Let's add indicators on those sorts of things to our typical clinical indicators and see how that changes our retention and viral load indicators. I expect that there's going to be some correlation, and Ade a moment ago was talking about resources. There's many people, and unfortunately a colleague from PEPFAR was not able to join us on this panel, but from this donor perspective, there's a lot of concern about, we definitely want to increase the quality of services. We would very much like to see it happen in the most efficient way possible for the health system. So weighing those two things out. I don't think, there are some people who still think differentiated care is going to save money, but many of us would like to just see that money go further. Let me stop there with the caveat that I have one other point, I'm taking Ade's cue. A place that people do have concerns about equipoise, where I think that a randomized controlled trial, or at least a big implementation trial is going to be needed, is DOTS. I think our TB colleagues could potentially learn a lot, or at least I always struggle to say this, that we're doing a great thing, you should learn from us. But I think that there's some important conversations, starting maybe just with the TB HIV patients. If we're giving them 30 days or 60 days of HIV medicines, why should they be coming back every day for a TB pill?
Thanks. And just to build on that, I do think there are some knowledge gaps around the implementation. So this next phase, as we look towards 2020 and 2030, it's all about the implementation. So over here, we have a list of things, the what's, and there are lots of what's. And over here, we have the people who need it. And some of it is as simple. I saw one of the questions as, aren't we overcomplicating this? But some of this is really simple. So one of the great quotes that I picked up was from Prospect, who said, don't expect adolescents to come and pick their drugs up at 4 o'clock in the afternoon when they have school. I mean, that's really simple. And if you take this patient or client-centered approach to services, it really does make sense. So from my point of view in terms of research, as Virginia said, across the whole cascade, we really are looking at prevention, treatment and care, and there's a long way to go. And it's great that WHO and IS are digging deep on the information, but there are gaps around. If you look at certain regions, the real gap is around the first 90, so getting people tested. So that's an area where we want to talk. And then for the different key populations, it's really about understanding your cascade and looking at for each country where you have to go. Let me start with that.
So to both of you, we know central to the success of differentiated service delivery models, for especially ART, is the involvement of communities. We cannot have this program succeed if we do not involve folks who are recipients of care and their families and their communities. So what is your take on the support of these communities in kind of making these programs successful? And when I mean support, financial support, because, we know that there has been this attitude about people thinking that communities will be eternally volunteers. So what is your take on that?
Do you want me to start with that? Okay. So I think that's a very important question. And as I sit here representing the Global Fund, and I saw the figures that were presented. I mean, we can go back and look at the figures. I'm not sure that those particular figures are right. But what I will say is I don't think we fund the community enough. I don't think we fund the particular groups enough. And I think we should do more. But also to say for the Global Fund, the Global Fund requests come from countries and they're country owned. So it's really a conversation which needs to be had in partnership to get the right resources to the right places. But certainly this won't succeed unless we invest more in communities. I mean, that's a given for me.
Peter?
There's no question about the importance of involvement of the communities. And I think sometimes we conflate the active, organized civil society organizations and involvement of the communities. And it's an important distinction to make that if we're focusing, one of the things that differentiated care focuses on is thinking about the segments of the population. We're not trying to necessarily take this public health approach that has succeeded so well and provide individualized medicine, but we are trying to make sure that adolescents get something that's maybe a little bit better for them, or that this community that is maybe served by this one clinic, the only clinic that's within 10 kilometers of them, is responsive, the clinic is responsive to that community's needs by reaching out to them and seeing what they actually think of the services that are being offered. So there's that distinction, which I think is really, as I mentioned earlier, it's sort of the next threshold of information. On the point of involving the community, the more active or organized civil society organizations, I think it has to be critical. They're the key voices at the table, and I think we are already working with ITPC and other more local organizations to try to make sure that those voices are there as both advocacy and as implementers. And Zimbabwe's got a great example of an organization called ZNPP+, which is an active provider of community adherence groups.
Thanks to support from the Global Fund.
Yeah, thanks to support from the Global Fund.
Absolutely. And maybe just on that, so as I mentioned, our funding, our business model is we fund allocations to countries, but this allocation round, we have set aside 200 million to fund specific areas where we want to catalyze progress, so around key populations, young women and adolescent girls, and regional grants, such as the one that you mentioned, to really get the money where it needs to go.
So this question that's not going to go away unless we address it, at least for this audience, is what does differentiated care look like for non-stable patients? And I would be interested to hear a little bit more around this idea that maybe some of our patients who are not adhering to their treatment is because the system doesn't work for them. And so I'm a little bit hesitant to say that what they need to do is have more interaction with the health service when maybe they stand to benefit the most from being, like having their services delivered differently to them. And so how comfortable are we of maybe seeing these patients, maybe seeing them less, or maybe at least committing to and supporting them being involved in some sort of group model where they can see someone who's doing well on their treatment and maybe get that kind of peer support they need to be adherent? Are we there yet, or do we need to keep making them come to the facility?
I mean, to be honest, I would ask that question to the particular communities and groups which are affected. That's where the answer comes. So if you get a group of young adolescents, as we heard, and ask them, what do you need? And you heard some of the examples there. So rather than, very often we try and fix everything through the clinic. Sometimes you have to, as we've said, you have to go back to the groups and ask them what they need. There was a piece of work done, I think done in Uganda, in Zimbabwe, amongst other countries, which actually asked patients what they needed and what they wanted.
Shocking.
And, yeah, really shocking. And improved, I think it's there in the literature, it actually improved the service delivery and the uptake and adherence by actually giving individual clients what they need. So I think that's an important point. I don't think we're there yet, but I don't think that we get there by, if somebody's not adherent, getting them to come every month. I think we ask them what they need to do. Actually, I have to come, so I have to travel 30k to get to clinic, and I don't come because I don't have the money. So rather than making me come less, you make me come more. For example.
Exactly.
I don't have too much more to add. I think that's also, there's an issue. It's not a reason not to start with what we know. We know about about what to do with stable clients, and I think it's interesting to see already that what WHO has put in their guidance as to what the stable client is, Zimbabwe has modulated to what is appropriate for their setting, and I think other settings will do similarly. And I think that it's going to be very obvious that there's going to be patients that are not being that are falling outside of those categories, and also for those of you who may have attended an oral abstract session yesterday, it's actually fairly difficult for healthcare workers to figure out who is eligible or ineligible if maybe that viral load test didn't come back or that CD4 is not available. They're too busy. This person who is ineligible maybe winds up in the eligible category. So having such high expectations of classifications is unreasonable. I don't think that it's actually going to play out, that we're going to be able to so simply see this group is unstable and they're going to track them to this way and this group is stable, because somebody who's unstable today could be stable tomorrow, vice versa. People are going to end up going to the models that they're comfortable with and the ones that the healthcare workers are best able to provide for them.
And we've got some questions on data here, and there's an assumption in this question that if data comes from communities, it's going to be of poor quality. I'm just wondering if there's anything around data in regards to differentiated care that kind of keeps you up at night as people who very much like data and like those who are receiving your funds to show what they're spending their money on.
So maybe I'll start while Peter thinks. So I mean, it's great that there's been a question on data, because data is critically important for this. And if the ambassador Burks was here, she would say you can't get enough of data. So I think it's right. And we actually do fund, as part of that, as part of our set-aside fund, we actually do fund some data initiatives to support DHIS2 and other data platforms. I think it's two things to say. One is it's critically important. Two, I think the assumption about data in the community is not being as good, we'd have to have a conversation about that, whoever wrote that. But the other thing is we do have to build routine data systems and try and think, not to add more indicators, but try and think what are the key metrics we want to track in order to track some of this. And I know that's something that Peter has an interest in, so maybe you want to build on that.
I think we should move on to one of the other questions. I don't.
What would you like to answer?
I think I feel obligated to answer the one on top. I'm not sure what the person and the other voters, this is a lovely technology, we're thinking, but in fact the foundation, the vast majority of our funds that are in the HIV team go to very high risk. Most of it goes to vaccine projects. Those of you may have attended Tony Fauci's talk yesterday. A lot of the work that he was describing on BNABs, the foundation is co-funding. Differentiated care is on the delivery side of things. Those of you who follow the foundation, having an interest in the delivery side of things is considered a little bit risky from the foundation's point of view, and we're really lucky to be able to partner with the Global Fund and PEPFAR and other really much more substantial in terms of resources funders than we have. So our funds go to, we see differentiated care as a place to be a little bit of a catalyst to help countries do what they want to do already, what the clients want to do. One of the nice things about these concepts is that it is serving all stakeholders' purposes.
So I think what I'm going to do is just ask if you have any closing comments, or if there was anything that kind of caught your eye that you'd like to comment on, and then just to say to the audience that we'll do our best to answer some of these more difficult questions, or potentially questions where we'd like to redirect you somewhere in the weeks leading after the conference.
So I'll just pick up, just to say that I've never used this technology before. It's amazing, and it's really good. There are some really good questions coming up here. I'll just pick on two. One was on procurement and supply systems. In the case there, it's on Nigeria. But again, just to say that as part of our work and the work of our partners, we are investing a lot. Again, the health system's critical. It's critical to be able to supply 3 or 6 months of treatment, and making sure you don't have stockouts. That's the last thing you want. So that is an area. I'm not going to go into more detail, apart from say that I think that's a really important area, and thanks for the question. And then the other question, which is gone now. So I can't see it. It's gone. So I'll leave it. I'm
gonna close with the first question, which is hopefully where we started. Because I think that many people think that, yeah, what are we doing here? Is this just sort of stretching our resources further than we need to go? And many of us already know, but to state it, the majority of the resources that are used to provide ART care go to the drugs themselves and go to the human resources. And I think Meg actually mentioned earlier, what if we think a little bit, instead of about only what the health system is providing, we think about what the patients need to do to get to the services. And maybe the patients that have needs, they want to go to, or they're sick, and this was Meg's point, let's let the sick patients, or those, whether they're really sick or they're people who just want a little bit more of the laying on of hands that some of us are familiar with, or went to medical school, we've got this, as doctors, we have this dream that the laying on of hands is important to patients. But to some it is important, and they're willing to walk the 10 kilometers to go, right now, wait a long time and have a few-minute interaction. So if you think about resources, if you add in the client side of things, I think that we're trying to use everybody's resources more efficiently. If that healthcare worker, instead of seeing 100 patients today, can see 50 patients a day, if that patient, or excuse me, I keep using patient, if the client only has to come every 3 months, or in the Zimbabwe model, as little as once a year for a clinical visit, that's much better use of resources. And again, this is patient or client driven. If clients want to come every month, I don't think that many places are going to stop them.
So on that note, in the interest of keeping with time, I'd like to thank you, the audience, for your questions. There's some really tough ones. I'd also like to thank the panelists for their earlier presentations, and for everyone to sticking to time so that we could actually try out this technology and have this conversation. Thanks to Ade and Peter and my co-chair Bactrin. I'd be remiss to not give a plug for a couple things. So one is that whatever print resources we have left are available as you exit today, but that's not necessarily convenient for everybody, so we have everything on credit card flash drives if you'd like to pick one up on your way out. Or you can visit www.differentiatedcare.org, where you can also download things like the Operational and Service Delivery Manual that Dr. Apollo presented from Zimbabwe. And thanks very much. We hope you can maybe join us with Prosper for the Adolescent and Young People Workshop later today. Thank you.